I'm Mark Albert, and welcome to the September ASJ Journal Club presented by the Young Aesthetic Plastic Surgeons Committee. Tonight, we'll be discussing the article entitled Lifting the Anterior Midcheek and Nasolabial Fold, Introduction to the Myelofat Pad Anatomy and its Role in Longevity and Recurrence. So before we begin, we encourage everyone to ask questions in the chat box anytime tonight, or at the end if you'd like to turn on your video and ask a question or make a comment, that would be wonderful. Tonight, I'm joined by Dr. Denise Sarhadi. She's going to be presenting poll questions to you, and she'll also be the one to relay your questions from the chat box to our speakers at the end of the session. So tonight, I'm going to begin by introducing everyone, and then Dr. Minelli will tell us about his article, followed by commentary by our two discussants. So as far as introductions, let's start with Dr. Lennert Minelli. So he's the first author on this paper, and he's going to be presenting tonight. He did general and plastic surgery at the University Hospital of Leuven in Belgium, and then he started a fellowship with Dr. Brian Mendelsohn and the Melbourne Advanced Facial Anatomy course. And this research that he started quickly evolved into something so significant that it became the basis for a PhD through the University of Groningen and the Queensland University of Technology. The presented work on the myelofat pad and nasolabial fold is part of this thesis, reevaluating the facial anatomy and surgical implications. Well, I'm really excited to hear more about this, and I thank you for being with us tonight, Dr. Minelli. Our first discussant will be Dr. Richard Warren, who certainly needs no introduction. Dr. Warren, a clinical professor of surgery at the University of British Columbia. He's the chief of plastic surgery from 1992 to 2003. He's past chairman of plastic surgery with the Royal College of Surgeons of Canada, past president of the Canadian Society for Aesthetic Plastic Surgery, past president of the Northwest Society of Plastic Surgeons, and past director and trustee of the American Society for Aesthetic Plastic Surgery. Dr. Warren is currently medical director of the Vancouver Plastic Surgery Center, where his practice is limited to aesthetic surgery of the face and breast. Thank you so much, Dr. Warren, for joining us tonight.
Thank you.
And our second discussant also certainly needs no introduction, Dr. Val Lambros. He's someone who has a long interest in facial dynamics and the use of volume in the face. He's interested in facial aging, and he ran a 15-year 3D study of normal facial aging. He published a 2020 paper entitled Facial Aging, a 54-year three-dimensional population study, which is pertinent to tonight's discussion since he addressed relative deepening of the nasolabial fold, among many other landmark findings. And in his own words, he says he's now retired from clinical practice, but not from curiosity about how things work. So thank you for joining us, Dr. Lambros. So let's get started. We'll turn it over to Dr. Minelli to share his screen and discuss his article.
Hey, thank you so much. So does everyone see my screen?
Yes.
Yep.
So I want to thank the organizing committee for selecting our latest article in ASJ. So we'll be going to talk about the anterior midcheek and nasolabial fold, and we're going to introduce the myelofat pad and its role in longevity and recurrence after facelift surgery. So I have no conflicts of interest to disclose. So the nasolabial fold, how is it treated in facelift surgery? Well, when I first arrived to Australia, I asked this to many surgeons, including my mentor Brian Mendelsohn, and the general opinion was that especially when doing the deep plane facelift, there were some disappointing results on the nasolabial fold, and we can see this in a case here from another surgeon that went to the Mendelsohn Advanced Facial Anatomy course and did the deep plane facelifts, started doing deep plane facelift, and her main complaint was, well, what about the nasolabial fold? She said, I get great results, in the periorbital area, we get great results at the jowl, the neck, but the nasolabial fold is somewhat lagging behind. And as you can see in this case, it's when you just focus on the nasolabial fold, it's very hard to see which was the pre-op and which was the post-op. And so this is a video of Louis Vasconez, and I like this because this is giving a great look at what's happening in surgery. So when performing a deep plane facelift, releasing the zygomatic teens ligaments, and then redraping the face in a superlateral direction. You see this smile versus no smile phenomenon, which Dr. Vasquez often refers to. But you could also see that there is a lot of tension on the skin. And so I was, of course, that is the young Lennert. I hope I still am young, but I'm really young. And I said, Dr. Mendelssohn, I think this tension is on the skin. And could it be that the lift is maintained by tension on the skin? These were questions that I had, and my mentor Brian Mendelssohn said, this is not possible because we are of course deep in the pre-zygomatic space over the zygomatic major muscle. The suture is placed deep in the myelofat pad, and so we were kind of like, okay, what's going on? And even though he didn't really believe me, he said, he allowed me to pursue this investigation in this area, which shows what a great mentor he is. And so what did we do? We went to the lab. We did first a feasibility study on 21 cadavers, and we already found out lots of different information. But most importantly, we wanted to really make sure, because most plastic surgery studies, often they are just anatomical studies with dissections, but to get a much better level of evidence, we wanted to really make sure we had some extra points of evidence. So what we did was we did extra to these 21 cadavers. We did a definitive study doing standardized layered dissections on 15 fresh cadavers. And when I say fresh, it's really fresh. So the bodies that we used, that was from people that were deceased. They called me up, and I went to the lab to dissect them without them ever having been frozen. This is particularly important for the mechanical testing that we did then later on. So these were all done on specimens that were actually frozen in a rapid nitrogen submersion facility, so that we didn't lose any of the real freshness of the tissues. Subsequently, we also did histology on 6 hemifaces, sheet plastination on 10 fresh cadavers, and micro CT on just 1 fresh frozen cadaver to get a three-dimensional ID of these of the area. So what did we find? So first, microscopic investigations, we got a broader understanding of anatomy. Now, this is too much to go into detail, but because as you can see, this is very, very detailed microscopy. This is sheet plastination that you can see on the right lower side. You can see micro CT, and this is the histology that we did on the area from laterally to medially. But basically, what we found is that the myelofat pad, so the fat in the cheek area, the malar fat, the fat over the buccal area and over the jaw, that has this almost a honeycomb structure with connective tissue, retinaculum acutis fibers that kind of form the matrix or the honeycomb in which the fat is housing. And this is important for the later the things I will explain now. So there's 2 things I want to say first before we go further, is that we have a distinction a little bit between the malar fat pad of the past, which Owsley described, and our myelofat pad that we described. And the second thing is that we really want to make sure that the nomenclature is correct. So the nasolabial crease is different from the nasolabial fold. And what do I mean by this? Is that when you're looking at this area, the malar fat pad originally was described as a triangular structure bordered by the nasal base, of course, the nasolabial fold, the lower orbital rim, and then the zygomaticus major. It was kind of like a triangular structure like this. But what we found is that this extends over the buccinator into the jowl fat, and that whole area has one similar structure, at least macroscopically, and therefore we call this the myelofat pad. This was an idea of the senior author on this paper, is Bill Little from Washington, because myelo is Greek for cheek. And then what's the difference between the nasolabial fold and nasolabial crease is that the nasolabial fold is the bulge which hangs over the crease. So the bulging of the myelofat pad is what we call the nasolabial fold, whereas the crease is the sharp acute barrier that marks the start of the upper lip aesthetic subunit. And so if you look at it from above, this is the bulge, this is the nasolabial fold, and then of course you have the crease, the start of the upper lip subunit. So that's the first thing. Then what we found is that in youth, this is a nice full plump structure which has this connective tissue that comes from deep to superficial. That's the retinical acutis fibers, and the fat extends very high to create a very nice lid cheek junction. Now, when you age, especially over the orbicularis, you see a much deflation of this fat, which will accentuate the black circles around the eye and also the lower lid bulging. And then when you go lower into the myelofat pad, you will see that the deflation of this area causes some bulge, some ptosis of the skin, which will hang over the crease. So it's kind of the form of a teardrop. Now, then of course our main goal was to see whether whether in a facelift, when you put the suture in the deep myelofat pad, the deeper structure, the tension is transmitted through the skin or through the fat. That was our main question. And so
cutaneous dissection.
I'm going to show this video here. I hope that you can hear it.
Shown here, the orbicularis oculi and the zygomaticus major. A nerve branch is running over the zygomaticus major in this case. A suture is placed in the superior aspect of the malar fat pad. The malar fat pad extends more superolaterally at the junction with the arch of the zygoma, but the suture was placed more anteriorly over the body of the zygoma, over the zygomaticus major. When tightening this suture, you see a nice redraping of the malar fat pad and an effacing of the nasolabial fold. The same amount of tension placed on the same suture in the same malar fat pad does not have the same effect on the nasolabial fold and crease skin redraping, indicating that the tension is not transmitted through the malar fat pad, but rather through the dermis.
So I just want to make sure everybody understands this, because so when you're looking, if you take a look at the corner of the mouth and the nasolabial crease, just take a look here on what the effect is of putting the suture or lifting the suture. So you can see here you have a massive lift of the entire area, including the nasolabial crease and even the upper lip. You can see some inversion of the upper lip. That's what Louis Vasconez called the smile versus no smile. So this is a no smile, and then of course this is a smile. So when you do the same thing in a malar fat pad, when you remove the skin and now you look at the corner of the mouth in the same area, you can see that there is almost no movement going on. You see that the corner of the mouth doesn't even move. If you look at this area, it doesn't even move. So you can see that the fat is stretching. So that was the first argument. This is just simple gross anatomy. So that was our first argument. But of course, this is not where we stopped. We did we went a step further. And one step that we did was the histology. So I'm gonna just show you what's going on here. If you do this dissection, you do it in the pre-zygomatic space. Okay, you release the zygomatic ligaments and you put a suture deep in the malar fat pad. Then you have an area which is released, which is dissected. That's right here. And then of course you have an area which is not dissected, and that's this area. So we mark that on the skin with a red area and a blue area. The blue area marks the dissected area, whereas the red area is the non-dissected area. And obviously back when he described this Mitchik lift, he described it as if the malar fat pad could glide over the zygomaticus major. That's what he described in his 1992 article. And so that's what people think that's happening. So that it would move en bloc, kind of as a whole, like an ice cube. But this is not what's happening. This is not what's happening, of course not, because the myelofat pad is still attached to the zygomaticus major. So instead what's going on is that, I mean, we put this little figure here just for fun, but what's going on is that the area which you released can of course be redraped with no effort. That's perfect, but the area which was not released is moving up passively through tension on the skin. And how do we know this for so certain? Is that because we did this on a cadaver, on 3 cadavers actually, and we compared left and right on histology. So here you can see the cross section of the area in histology. So you see the nasolabial crease here, nasolabial fold right here, and you can see the myelofat pad just hanging down. Then we put this on the other side. We put the suture in. We lifted the myelofat pad through the prezygomatic space over the zygomaticus major, putting a suture in the myelofat pad just over the zygomaticus major. And this is what you see then. So you can see that the connective tissue now is not hanging down anymore. Now it's getting pulled upward passively by tension on the skin. So this is the second argument that we had. The second argument that not the myelofat pad, but the skin is taking the tension even though you place a suture very deep. And then the third argument was what we got by doing a mechanical testing of this region. And with the mechanical testing, we fixed the nasolabial crease in a machine. So we took the whole cheek off, right? But I'm just going to show you how the principle works. So we took the whole cheek off. We fixed this part to one part of the machine. The other part was we fixed the myelofat pad. So not the skin, but the myelofat pad in the deep aspect to the other side. And then we did mechanical testing. So basically stretching, lifting, so to speak, the myelofat pad and measuring the tension on the nasolabial crease. And this is what you find when you do that with the composite flap, the myelofat pad plus the skin. And you see that for each millimeter of lifting, you can see the corresponding rise in load or stress. Now, when we did the same thing then we did exactly the same thing. We left everything attached. We just removed the skin very, very, very carefully. Just removed just the skin, and then we did the same exact test. And what we found then is that the curve completely changed, right? So for each lifting now, there was much more stretching of the area. And so what did we find is that the skin plus the myelofat pad, so the composite flap. Oh, sorry, I just went back. I have to go forward. So we found that the composite flap has a much shorter low resistance expansion region than the myelofat pad, average of 5 times less. That means that the myelofat pad can stretch out passively much more. So for a 5 centimeter myelofat pad, this corresponds to 1.5 centimeter of extra length that you have. Secondly, the stiffness marked by the length of the upper curve is 2 times more for this when the skin is still attached. So what does this mean for a facelift? For a facelift, this means, you know, we got from the literature that the facelift is often sutured at around 12 Newton. So that means that when you put 12 Newton on your suture, you will have 2 times more lifts when you have it just when the skin is removed. So what does this mean in actual terms? If you want to lift the whole area with 1 centimeter, so 10 millimeters, that means that at that point the skin is already on maximal load, while the myelofat pad is still there is still no load on the myelofat pad. So in other words, when lifting the upper part of the myelofat pad plus the skin, so that's the composite mid-cheek lift. When you do a composite mid-cheek lift with 10 millimeters, you know, with notable lift of the nasolabial fold and the upper lip, then at that point, the rest of the myelofat pad is still stretching passively while the overlying skin is already approaching maximal stress and hence taking all the load responsible for the lift on the nasolabial fold. And that was the key argument that we needed to really conclude that that in a mid-cheek lift, the skin is taking all the load distal to the placed suture. Now, what is the consequence on this on longevity and recurrence? That is that if you do a deep plane facelift, just like we showed initially, with release of the zygomatic cutaneous ligament, and you're lifting it like that, that means that because you changed in your architecture from a hanging down position in an upward lifted position where the skin is taking all the load, now the flap is supported just by skin tension. And we know from skin-only facelift that skin tension itself is not a good vector for stress in the long term. So that's why we think that that explains the recurrence on this nasolabial fold in these type of surgeries. So whereas you get a very good effect on the periorbital rejuvenation, you know, a deep plane facelift has the effect of, you know, you're taking the volume from the cheek a little bit and you're moving it to in the periorbital, which Sam Hammer always called high and lateral volume. You know, it's kind of a stigmata of facelift, but in a way we tend to like it. And the lower part of the milo fat pad and nasolabial fold has not that long-term effect due to this tension on the skin. Of course, this is much worse for no-release facelifts such as thread lifts, max lifts, all the lifts that actually put sutures in non-dissected areas. So with a max, this is for example a max lift, you do subcutaneous dissection, you put a loop suture and you're pulling it upward. Now not only the area where there's no dissection low down is affected, but also the area superior, because at that moment you lift the tissues which you haven't dissected from below, so they are not released. So at that moment the skin is taking the load from everything distal to the suture, and then superiorly from the suture, you will have the tension held by that one suture, which also causes cheese wiring, as we all know. Then you could say, well, then a good alternative might be to do an extended deep plane. You go all the way down to the nasolabial crease. And that would be very true. But not if you still place a suture laterally. So for example, if you can you see my face? So if you go into the deep plane from let's say the lateral canthus to the angle of the mandible, and you say that that's the deep plane entry point, you enter and you do the work to dissect all the way to the nasolabial crease, but you would still place your sutures laterally. Then this is all for nothing, because the fat is still hanging passively down from the skin, and the effect will not be as intended. So a real alternative would be to do an extended dissection over the zygomaticus major, and also place the suture much more forward, much more distal, so closer to the nasolabial crease. And this is now what's done by Mendelssohn, you know, by my mentor, by Rick Warren, of course, by Ruth Brauf, by others too, Chachi Kao. Basically placing, not only doing the dissection further forward, but also placing the suture further forward. And that would be a first alternative that you could use to circumvent this situation. Another alternative would be a milo fat pad plication, or what it mostly used is the anterior smash plication. But because we described the article that the smash doesn't exist, we tend not to like the term smash that much. But basically the anterior smash plication is the plication of the milo fat pad in the mobile area. And this was of course first described by Bill Little, but now also used by Jim Grotting, Pelle Ciravolo, Rick Warren, especially in secondary facelift cases. And what does this mean? This means that you do a subdermal dissection, so leaving all the milo fat pad down onto the lip levator muscles, and then putting a suture, like a plication suture, to actually remodel or remodel the fat from a long but flat mass to a more compact and plump mass. And the idea would be that this can provide more long-term result because there is no tension on the skin. Yeah. So Okay, the only problem is that in this situation, when you do a smash, the smash application or an Milo fat application, this is done pretty low down because the volume which you want to the projection which you want is in the anterior cheek. This has the consequence that there is no volumization of the periorbital area, which you do when you do a composite lift. So often you're stuck with having to do lipofilling of the periorbital region to compensate for this thing. So this is, for example, this is just one example of a 13-year follow-up, which you can see that after 13 years there is still more projection in the anterior cheek than in the pre-op situation. This is an old result from Bill Little. And this is kind of the
plication line. This plication line is the line to which ptotic tissues are plicated. A first bite is taken into this line, and subsequently, the amount of lift that can be obtained with no tension is assessed, and a second bite is taken. A simple suture completes this plication at the corner of the mouth. A second suture is then placed at the plication line at the level of the jowl. In this cadaver, the jowl is of course absent, but the principle is here shown. So again, a simple suture is placed to lift the subcutaneous tissue, which is the Milo fat pad with no tension. More sutures are then placed along this plication line until all the tissues are lifted. Finally, a running suture is placed to smoothen the contours. This plication suture reshapes the Milo fat pad from a flat mass into a compact but plump and projected mass.
So that's the principle, and then the third alternative to this, to this recurrence of the nasolabial fold upon conventional lifting techniques is that you have to add volume to the depleted areas. You can do that with fat grafting, bone augmentation, for example, implant or hydroxyapatite or bone grafts. And this is, of course, all based on the work of Lambros, who demonstrated that there is much more than ptosis of the cheek. You have recession of the nasolabial crease in the area, contributing to this nasolabial fold formation. And of course, we also have the work for Alexis Rapala and Patrick Tonard, who showed that there is a 30% decrease of lip volume. So that's, of course, soft tissues. And then you have also the work of Dr. Richard Huggins showing that the maxilla, the sinus recedes with aging, also contributing to that deepening of the nasolabial crease. And due to the soft tissue and bony, recession, you could or you should rather restore this to the youthful proportions. So this is all a receded situation. And you can do lipofilling of the Milo fat pad. You can do lipofilling of the upper lip subunit, or do hydroxyapatite augmentation, bone augmentation of the maxilla, to all help restore that original youthful volume. So to conclude, the problem with the nasolabial fold is that in a composite mid-cheek lift, it is the skin and not the Milo fat pad that bears the load of the lifted tissues distal to the placed sutures. This explains the early recurrence of the nasolabial fold. And there's possible solutions that we proposed. One of them is the suturing closer to the nasolabial fold to minimize the length of the tension transmitting skin. Secondly, anterior Milo fat pad plications or anterior smash plications. And third, the volume restorations of the deflated tissues and receded maxilla. So with this, I want to thank you so much for your attention. And I want to really thank the body donor program of the Queensland University of Technology, because without body donors, we wouldn't be able to do high quality anatomical research. And finally, I want to thank Howard Webster from Melbourne for helping us with the development of these ideas. Thank you so much.
Well, thank you, Dr. Minelli, for really an excellent presentation, especially given the fact that it's 3:30 in the morning where you are in Turkey. So next, we'll turn it over to Dr. Warren for his thoughts, please.
Have you got the picture?
Yep, you're perfect.
Okay, great. we'd sure like to thank the Aesthetic Surgery Journal Club for inviting us to present this paper, because as you've heard, it was a real significant labor by Dr. Minelli, and a long-term project to get to this point. Also thank the Aesthetic Journal for publishing it. I've been doing facelifts for 35 years, and looking back on it, I think that the discussions and the publications have gone through various ages. And when I started, it was all about the SMAS and the platysma, because the SMAS had just been described and the platysma was being dealt with various ways. And then we went into an era where the retaining ligaments were discovered and described, and then the idea was to divide them and move the SMAS platysma with superficial fat. In the 2000s, there was a move to less invasive surgery, and this was short scars, mastectomy, max lift, that type of thing. And then we went into something I'm going to mention later, the age of volume, and now I think we're in the age of the neck. So looking at all of these ages, how have we gauged the success of our facelift? Well, one way is to measure patient satisfaction, and that's quite new. That's been in the last 5 or 6 years. FaceQ has come along. There have been colleagues of ours who have used this to see how happy their patients are. A lot of variables in this, including how much the patients like the surgeon, how other things went with their case than just the result of the surgery. How much younger do our patients look? This arguably would be an objective way to judge our results. And this was published by Jim Zins from the Cleveland Clinic, and very reliable assessment, as it turned out. A bit disappointing to find out that his average facelift looked 5.23 years younger, but it is a way to objectively compare facelifts from one group to another. But in fact, that's not what surgeons have done. What surgeons have done historically, we've looked at anatomical entities on the face. We've looked at the jowls. How much are they eliminated? How is the jawline defined? We've looked very carefully at the cheek contour. One of our co-authors, the OG curve, has been described by Bill Little. We looked at the neck contour in great detail, and the nasolabial folds and the marionette lines. And I think surgeons have pointed to their improvement in all these things, but arguably the worst results have been in the nasolabial folds and the marionette lines. This paper deals with one of those two things, the nasolabial fold, as one anatomic entity of the things that we've been measuring. So this is an anatomic study, this paper. I was involved really as one of the clinicians to offer some clinical correlation, but it's pure anatomy. The anatomy of the fat and the soft tissue that you've seen in great detail described around the nasolabial fold, and the potential reasons why in the clinical setting our corrections of that fold don't work during facelift surgery. These are the 4 commonest facelifts done in the world today. This was at a poll done.
Can I interrupt you for one brief second? I apologize. Are we supposed to see a visual aid as you're speaking?
You're supposed to see slides, yeah.
Okay.
No, we don't see this.
You're seeing none.
We're only seeing you.
Well, that's not what you're supposed to see. I've got, let me see here if I'm sharing the screen here. I think I'm sharing the screen.
I'm making you a co-host again. Could you try one more time?
Yeah. Try this again.
Now it's there.
There we go.
Oh, I should have asked you at the beginning if you're getting this. So anyway, I will start over again. Sorry about that. The sharing didn't pop up. So we'll go back to the beginning. Yeah, what I was, well, this was the opening slide I showed. And these are the ages that I was talking about, from platysma, ligaments, less invasive surgery, volume, and then the neck. And I was just saying that patient satisfaction is a way of measuring patient or results. This was the FaceQ slide. And then I mentioned about how patients can look younger, and we can measure this objectively. This was the Jim Zins paper in ASJ in 2018. And this was the result that he found, which was that his patients anyway looked a little over 5 years younger. Anyway, what I was mentioning is that that's not what surgeons have done. Surgeons have tended to look at how they've changed various anatomic parts: jowls, jawlines, cheeks, neck, nasolabial folds, and the marionette lines, and with arguably the last two being the worst treated. And this paper is all about nasolabial folds, looking at the soft tissue anatomy of that area and the reasons why our surgery may have failed. These are the 4 commonest facelifts done in the world today, in order, actually, with plication being the commonest. This is from a survey that was done at an ASAPS meeting a couple of years ago. And these all work because we're shifting the superficial mobile fat in a superior lateral direction. That's why they all work to some degree. Now, I have to give a bias because I think all surgeons have it. My bias is that I think it's better, you get better results, more long-lasting potentially, when you undermine the SMAS superficial fat and lift it. And I do something I call a high to low SMAS. I do plication sometimes, and if I do that, it's either an oblique pattern or a transverse pattern, as Lennert showed you. And I'll use plication in thin, older people with mobile superficial fat, the type of case where you open the case and the tissues are very thin, the tissues are already mobile, and you say to yourself, there's not much advantage in me undermining this thin, fragile, superficial fat layer. And the other place I'll use plication is in secondaries. Secondaries where already the deep plane has been lifted. Maybe I don't want to dissect once again into the deep plane. And if I raise the skin flap and find it mobile, I trust my sutures going into that scar tissue in this secondary case more than I do putting plication sutures into just superficial fat. And that raises a question about the plication that Dr. Minelli showed you. Plication is suturing fat in a primary case. And I think that you could make the argument that plication is just as likely to fail because of cheese wiring as is a MAC suture, for example, because in both cases we're using sutures in fat, whereas in a secondary case, there's scar plus fat. So anyway, this is the operation I do just to give you a perspective on what I'm about to say. I call it a MAP lift because it's in the anterior portion of the face, and it's the platysma and the SMAS. I always divide the sternocleidomastoid from the platysma, and I sometimes do a transection in the neck. So clinically, you can look and see what this looks like in the operating room. This is the purple line is where I enter the space deep to the superficial SMAS. And the melo fat pad we're describing is just anterior to that purple line. So the melo fat pad really is a term to describe the superficial fat of the cheek. And for some reason or another, over the years, we've divided it, and we've talked about the lower part being the jowl and the upper part being the malar fat. But in fact, it's the superficial fat of the cheek. It's just perhaps a little thicker in these two areas. And all of these surgeons, from Bosse down to Yusuf and Owsley in between, they all made the argument that malar fat pad ptosis, which looks like a triangle in most of their diagrams, that thick pieces of superficial fat sag because of attenuation of ligaments. This is Owsley's paper that Dr. Minelli mentioned, and he published this in 1993. He called it Lifting the Malar Fat Pad to Correct the Nasolabial Fold. So he was on the same wavelength as we are. And this is what he said. He said, surgical corrections of prominent folds is enhanced by undermining the malar fat pad, advancing it laterally with traction on the skin flap, with an additional upward fixation by sutures between the lateral edge of the fat pad and the subcutaneous fascia. So to do that, he separated the superficial fat into two pieces. This is the malar fat pad that he lifted, and this is the rest of the superficial fat down here. And he had two different flaps. He treated the malar fat pad as a separate unit. I bought into that theory, and for most of my career, I've done this. I've raised the malar fat pad off of the orbicularis oculi at the very top where it's thin. Then I've gone down and I've raised it off of the zygomaticus major. This is just dividing the ligaments here. And after I get the ligaments released, I do sort of a clinical test to see if I've clinically released it enough. And once the ligaments are released, I'll usually go back to the zygomaticus major and then dissect further down the zygomaticus major. This is the edge of orbicularis here, and you can see the zygomaticus major goes inferior to that. I'm just putting my finger on the malar prominence there. Looking at another anatomical dissection, this is my own. The upper component of the superficial fat, as you can see, overlies the orbicularis. So to raise this upper part of the fat, the myelofat, you don't have to go under the zygomaticus, or excuse me, under the orbicularis. You can raise it on top of both muscles. Hammer's composite flap was not that. He went under orbicularis and under the fat. But what I just showed you is raising this fat off of the underlying musculature. So this is what it looks like in the cadaver lab. This is the zygomaticus major. This is the orbicularis. This is the malar fat, the jowl fat down here, and this whole thing we would now call the myelo fat. This is what it looks like from another view. And as Dr. Minelli mentioned, I became convinced that to make this work, I had to go further down the zygomaticus major so that I could put a suture as close to the nasolabial fold as I could to help lift this fat pad up. So back to the our paper. Perhaps the thing that I contributed most to this paper was the idea that this fat pad is not a round pancake. It becomes a teardrop, and it becomes a teardrop with age, so that if all we do is undermine the top of the teardrop and put some sutures in, we might be able to lift the top of the teardrop, but the bottom that really matters, unless we do something else, is still going to be right where it is. Going to figure 8 on the article, I've done my own little morphing here. And what I'm showing is that if you dissect further down the zygomaticus major and you get a stitch in lower down on the fat pad, you'll have a better purchase on this sagging lower part, the part that really matters. With this kind of effect, with a better lift of that lower fat. And this is how I do it. Once I lifted it up, I've got deep sutures. I use PDS, and then as a second row of sutures is 3/0 Vicryl. So let's see how this works in a clinical setting. This is a woman I did that exact thing for. She's 6 months out, and I'm pretty happy with her jowl correction, her neck contour. But what about the nasolabial folds and the marionette creases here? They're a little bit better. Everything else is pretty good. They're a little bit better at 6 months. This is an excellent result. In the neck, I did Mario Pelli's LSD procedure. She's 24 months out, and you can see her nasolabial folds, they're better. If you dissect right in and look at them, they're not that much different. Everything else is better, but the nasolabial fold is, that little crease anyway, is still there. But she didn't have much of a fold. And I think a lot of the times we as surgeons fool ourselves with somebody like this. There's not much of a fold there, and we tell ourselves it's better, but there really wasn't that much to improve. 24 months out, same kind of thing. Now, this is, I would consider an average case of mine. She's 69, facelift, upper lids, and she is around 10 months out. And just look at those folds and creases. I've done that deep dissection that I told you about. So those folds are better, but they're not gone. And that has been my track record, and it's been the track record, I think, of most surgeons doing most types of facelifts. We have a difficult time getting rid of these folds and creases. I thought I'd put this to the test with a patient who is bona fide Ehlers-Danlos syndrome. She's in her 30s. I thought you should see what happens when you do this to somebody who has got this condition. This was the type of skin she had. And so arguably, if the skin was going to help me in any way, it would have. But this was the result. Minimal change, really, at only 6 months. A little bit better in the jaw. That was about it. So the other thing that Dr. Minelli mentioned, I just wanted to make mention of, was this paper. It came along in 1989, and Peter McKinney suggested, well, wait a minute here. If this is a fold, if it's a bunch of fat, why don't we just remove it? Why don't we suction that fat out and get rid of it directly? And others had done it before that with curettes. And I did a handful of these cases. So this case was my own from 1990. I did a limited dissection in those days. There was no fat grafting. And I'm going to do liposuction of that ridge. So let's see how this turned out. And you can see that I probably got a decent result on everything, maybe except the nasolabial fold. It's really not that much different, even though I liposuctioned the fold. But on this angle, you can kind of see that I did flatten it a bit, but To what end? This woman has a retruded maxilla. She's now got a flatter face than she ever had before. And I don't think removing that fat was the answer. So that brings me back to that first slide I showed, which is in 2010, as the age of volume came along, we finally understood which part of the face is losing volume and how we could correct that by adding volume. And I attribute this knowledge to two individuals, actually, Sid Coleman and our discussant tonight, Val Lambros, who really saw things that the rest of us just didn't see. And I wish I'd been the one who saw it, but I never did. But Sid and Val did. So I'm really looking forward to seeing what Val has to say about this topic and about how he would treat this woman with this recessed maxilla, loss of volume, and but a nasolabial fold. So thank you very much, and we'll hand it over to the moderator.
Well, thank you so much, Dr. Warren. That was really phenomenal. Well, Dr. Lambros, we'll turn it over to you if you don't mind.
Wow, that was extraordinary, Rick. I have to congratulate Lennert. This was a very complex and dense article that actually should have been split up into a couple. And it was really extraordinarily well done. You know, people have been looking in mirrors and doing this for 6,000 years, at least, you know, bronze mirrors. And you know, instead of look at it wistfully for a second, then go off and do what they need to do. So it's not, that's something that's in the human psyche. Just for kicks, when you guys go home tonight, I want you to do that. And instead of dropping it in 3 or 4 seconds, I want you to hold it for about a minute and see how well you like it. Because that look is actually, though it looks great instantly, and in some people it looks wonderful, in some people it puts them into the uncanny valley. It just looks a little bit bizarre. And I appreciate the reason to chase it, but sometimes the worst thing that can happen is that you get what you want. The assumption that's made here, and it's a noble assumption, that there's a problem here, we know we can fix it, all we need to do is study it hard enough and we'll take care of it. I think that in this particular area, and this just may be sour grapes because I don't know what it fits in, but in this particular area, you've got a couple of strikes against you before you even start. This is the most part of the face. I mean, it's moved back and forth and up and down, has to do this. And the labial fold is kind of a bellows. It gives you a little volume of tissue that you can move back and forth and will stretch for you. And if you take that away, the body wants to bring it back because it needs that to accommodate the motion. So even if even if you do a nasolabial fold excision, which is really the most efficient way to get rid of these things, some of it will come back because it has to accommodate the motion and the stretch. You know, the best results you get with facelift surgery are in the people who don't need it very much. And so if you do, you know, if the 45-year-old woman's going to get a spectacular result regardless. And so you can get some improvement that's actually relatively long lasting doing the standard maneuvers. But in general, it's not going to be very satisfactory. And in the 1980s, when SMAS facelifts were first, you know, coming into fashion, it was like a magic plane. People would start talking about SMAS and then get lost in this word salad of, you know, different meanings, as if there was a magical plane to work with. And I think that the tendency a little bit here is to consider, is to try to find the next magic plane, and I don't think that it exists. And so that's sort of one ball. The nasolabial fold is formed by thin tissue that doesn't expand and regular fat tissue to the side. If you're skinny, most of the fold doesn't come from laterally, even though the surgeons think so. It comes from medially, from the medial lip getting thinner. The biggest reason for nasolabial folds to occur isn't from subtle changes in the maxilla, it's from weight. You know, you put on a bunch of weight, you get big, thick nasolabial folds. So those are a couple of basic sort of loosely linked thoughts. I'll give it back to the moderator.
Well, thank you, Dr. Lambros, very much for those thoughts. I know we have some great questions waiting in the chat box, and Denise, if you don't mind, take us through it.
Absolutely. This was fantastic. Thank you guys so much. I love the study. I loved reading it. The presentations were fantastic, and I think the audience agrees. We do have a couple questions. Pedro Piccinini, I'm so sorry if I said that incorrectly. He said, could you please expand a little on mid-face lift where we can anchor this more vertically? I'm not sure who wants to take that question on. Dr. Warren? We're muted.
Back on again. The question was, how do we anchor a mid-face lift in a more vertical direction?
Yes.
Yeah. Okay. Just to expand on that a little bit, I didn't say this earlier, but this paper is really not talking about the mid-face per se. It's talking about the anterior part of the mid-face, which is really one specific part of the mid-face. I think that a lot of techniques get a good result on the jowls, you know, and that would be a mid-face lift result. The part that we're talking about is the most mobile, most anterior part that Dr. Lambros just finished explaining is subject to the most movement. That's the problem. So in fact, there are techniques that mobilize that mobile tissue and move it straight vertical and affix it to the infraorbital rim. And those would be approaches through the eyelid with drill holes in the orbital rim with a vertical anterior mid-face lift. I am completely without knowledge on that. I tried a few of them. I didn't really like it. I had one sort of ectropion that I struggled with, but I would say that is like the way that you could accomplish what that question is asking. Otherwise, it's not purely vertical. It's a little bit oblique in the best of hands.
Thank you so much. And speaking of the kinds of facelifts that everybody does, in our audience, about 40% do mass plication, another 40% do a deep plane, and then the fewest number of participants tonight do max lift and mass plication. And around 80% of us have issues with early nasolabial fold recurrence. I thought it was just me. So I really love this article. And a lot of our audience, about 80%, use fat grafting as an adjunct. One of our questions here, one of our participants.
I have a question for you. Was that a question in the poll you just mentioned?
Yes.
Did it talk about early recurrence or just
early recurrence?
Early recurrence, okay. Because I think arguably they're going to come back eventually. You know, if
one day.
If the late is 10
or long enough. Early recurrence, yes, 80% of us. And speaking of fat grafting, Aaron Stone in the audience has asked, he can never get a satisfactory crease effacement, so the nasolabial crease. So he almost always fat grafts it. Is he doing something wrong? And can you use surgical net sutures to improve your nasolabial fold crease result?
Well, I can say that I don't think he's doing something wrong. I do it almost all the time too, and I see a significant crease. And you know, the addition of fat is in that case not for volume as much as you're using it almost as a dermal filler. And so, for example, Tenard and Rapelli have described the sniff technique, the sharp needle intradermal fat injection. I think that's probably where he should be putting his effort rather than trying to add volume deep to the crease, because that really isn't going to do it. It would be helpful to add volume across the entire premaxilla. But I do think that targeting the crease, just like you would with a dermal filler, you can do it with fat, and that makes sense.
Yeah, I've done it for decades, and it's a rational way to approach it, but it's not a very efficient, nor is it a very reproducible way to do it with regular fat. Sometimes Most of the time it doesn't work. Sometimes it works too well and you get lumps in the fold. And those are the kinds of patients who have like thick tissues to begin with. Baman Gairon described a procedure whereby he made a little slit here and tunneled underneath a piece of SMAS. And he said he had great results with it. And I tried it for a couple of years. Most of the time it didn't work, but occasionally it did, which is kind of the perennial problem with doing this part of the area. You know, if there were an operation that worked, you know, there's no secrets. If there was an operation that worked, everybody would know it and everybody would do it. And that's just not the case here. And, you know, I'm perfectly willing to do it in the fullness of my age. I'm perfectly willing to admit that there's stuff that I don't know how to fix. And I'll come back and do some fillers in it later on and try to ameliorate it. But it's a difficult surgical problem, except for direct excisions, which are very efficient.
Val, I got a question for you. Did you ever try that Lennert technique of using a sharp needle to put the fat in the dermis?
Yes, whatever it was supposed to do, it didn't do it for me.
Okay, fair enough.
One more question, is nanofat better? My impression of nanofat is that it's great for skin texture, not for volumizing or effacing.
Well, yeah, nanofat is not fat. That's right off the bat. So if we're talking about adding volume or filling in a crease, then that's not what you want. And nanofat, in some ways, is a misnomer because it's created by destroying the fat cells and having what's left that you use. And you're right, for skin textures, skin quality, using microneedling to inject it, that type of thing, I think it makes a lot of sense for that type of thing, but not for this application.
The phrase mass delusion comes to mind.
Specifically pure graft. I'm not too familiar with pure graft, but that was a follow-up question for the nanofat.
There's a request to talk a little bit about the net again, as far as effacing the nasolabial fold. So Dr. Warren, I know you actually were one of the people who turned me on to the net way back when. Do you use it specifically for the nasolabial fold?
We're talking the hemostatic, Arsvold hemostatic net. Yeah.
Yes.
I do it in every facelift. This is not the topic of this paper, and it's changed my life because I go to sleep at night and I don't worry about a hematoma anymore. That's the reason the net was invented, was to prevent hematomas, and it does do that. Does it redrape the skin? I think it does. I think it's a serendipitous finding of the net, but you have to think about it. The net is sticking the skin down only for 3 days, and then you take the stitches out, but you have to undermine the skin that you're trying to reposition. So in fact, if it was going to work for the nasolabial fold, which I don't think it does, you'd have to dissect the skin flap right to the nasolabial fold. It would be a super extensive facial dissection right to the fold. I don't personally do that. I know some people do, but I think that if you were to do that, it would improve the fold a little bit, but don't forget the underlying fat is unchanged. So I don't think it would help that much, frankly. It helps in the neck.
Thank you. Any other thoughts from any? I mean, we have some world-class surgeons in the audience. Any thoughts or questions from anybody? We'd love to hear from you before we close.
You know, arguably this is controversial, as was Dr. Minelli's other paper, which determined that there is no SMAS. It's like the emperor has no clothes. So I guess I'd like to hear from Dr. Minelli about these issues. I mean, you may as well tell us about the controversy that you're facing. What are the criticisms you've heard about this this concept that it's the skin traction that's changing the fold or changing the crease?
Yeah, thank you, Rick. Yeah, it seems to be a very controversial, whereas in my view, after reading extensively on all the papers on the SMAS, it was never really proven. So I don't know why it's why it's so new. What we found is basically that all tissues that the only tissues that have long-term stable results upon lifting are the tissues that were undermined. That's the deep plane. That's same with the surgical net, and it means that if you have two tissue layers together, you have to do a complete separation of the two, and then move them, move the superficial layer from the deeper layer. And I feel like that when you do surgical net, the surgical net, people often say there's a lot of recurrence, but they forget that once you pull on the skin, they are still attached at the lowest part of the dissection, and so when you're pulling on this part, the underside also comes along a lot. So I know surgeons that make a big effort into, and I know surgeons that do nice, no, actually they do the surgical net for this area, and they make a big effort of course, keeping the lower part low, you know, the deep part, they pull that down when they put the superficial part up. And so this is not just for deep plane, this is also for the gliding lifts. And so this is the basis of all of our papers, where that, okay, you have a full release, extensive release, and a no tension redraping is very important. Yeah, our other paper on the SMAS, I guess this is not that new. It basically, what we show is that the SMAS is a surgical entity much more than an anatomical entity. Nobody goes and says, oh, you have such a nice deep flap, you know, in your abdomen. Nobody would say that the deep flap is an anatomical structure. Or, you know, so only when you release, when you did your incisions, when you take the tissue in your hand, then you could say, well, this is a deep flap. But I don't have an in vivo deep flap position, and the same thing for the SMAS. Anterior to your parotid gland, basically you have deep fascia, superficial fascia, and it's only when you do a subcutaneous dissection, and most people that do a dual plane facelift, they say you have to keep all the fat on the SMAS, otherwise you're going to have a hole in the SMAS. But that's just simply because the most of that SMAS is subcutaneous fat. If you remove all the subcutaneous fat, which we did in our layer dissections, once you remove all the subcutaneous fat from your flap, then you're going to do your deep plane, you're going to do your sub-SMAS dissection. You're going to be within that deep fascial layer, and the amount of tissue that you hold is the thickness of the deep fascia you harvest. And we know that more anteriorly we go, the more superficial the nerve goes, right, in the deep fascia. So that the deep fascia dissection has to be superficial. At that moment, that deep fascial layer is so thin that you're going to have a hole in the SMAS, and that's simply, you know, that's simply it. So it's controversial, but it's not new, I would say.
Can I ask one question? Lennert, what type of facelift do you do?
I only do, so I'm a fellow of Brian Mendelssohn, so I do whatever he does.
Okay, sorry. I was like, does he do a deep plane and he doesn't believe in the SMAS? Okay.
Yeah, so I guess the deep plane has great results for where you have where you have platysma. Basically, it's a platysma technique. Also, you have to understand that anterior to your masseter, there's no more deep plane, because over the buccinator has melo fat or malar fat, whatever you call it, coming straight from the buccinator straight up. So the only thing lateral, you have masseter, the small little bit of buccal fat, right? But the buccal fat is bordered anteriorly by the melo fat coming off. So if I take this, right, in my hand, at this layer there is no deep plane. You know, the buccopharyngeal fascia, you could say, well, that's a deep fascia, but you're not going to be dissecting in that. You know, you're not going to be dissecting deep to that, because you will go through all the buccal nerve branches.
Yeah, let's hope not.
Yeah.
Denise, can I just make a comment on just this discussion? You know, I'm a great believer in understanding anatomy. Anatomy is the basis of what we all do, and you have to understand anatomy, and the better we know anatomy, the better we're going to be in the long run. But the anatomy lab and what we're doing in the operating room are in some sense different worlds. The results that we get are driven by other factors, patient factors that really you can't completely capture with anatomy. So I think the idea of using surgical judgment, deciding what to do, the older I get, the more I feel having different facelifts for different people makes sense. That's why I do some plication sometimes. If somebody's got a mid-facial groove and they're older and it's mobile, I'll do a plication right in there to bunch up the tissue and fill in the groove, for example. So I think clinical decision-making still is paramount. We have to understand the anatomy, but in the end, it's the patient that matters, and we got to do what we think is right.
Now, I have to say that mechanically, smash facelifts and deep plane, those of us in the plastics world know that the deep plane came up with Sam Hamra. It was widely done by people who were trained with it, and then sort of faded, and then it was subject to some of the most spectacular marketing seen in the medical world. And there's a level of acceptance of it that's become almost de rigueur because of what the public expects and they've heard.
I agree.
Could I make another little point? Because in the poll, I saw that you were asking a smash plication versus deep plane, but smash plication is it's just everybody can do smash plication. You don't even have to go pretty far. I mean, you could do smash plication at the anterior border of the parotid gland. You could do it. You could do it much further anteriorly where you want to have it. And so I think one of the take-home messages should be that if you do application, do it where it's mobile. Do it close to the target tissue. That's what belittle. Basically, if you do the application very far, you're gonna still rely. Everything anterior to your sutures are still going to be relying on skin tension. You can pull it, but where you really want to reduce, where you really want to change the volumes is anteriorly. So I think you should change it into anterior smash plication and lateral smash plication, or something that you can distinguish it a little bit.
And I think that's a perfect clinical correlation, because if you're plicating over the fixed smash, you're going to accomplish nothing. You have to plicate so you move the mobile tissue. Exactly that.
Are there any other comments or any other questions before we close? Well, Doctors Minelli, Warren, and Lambros, I really can't thank you enough. This has been amazing, phenomenal, fantastic. Thank you to Phaedra for tonight, making it such a great success, and Denise as well. We'll see everybody back here in November for our next Journal Club, hosted by Ryan Austin and the ASJ Next Generation editors. And thank you all for joining us. Have a great night.
Goodbye.
Thanks, everyone.
Bye.